BD Chaurassia's Human Anatomy, Volume 1, 6th edition. Videos on osteology and soft part on FAQs. Regional and applied. Dissection and clinical. Upper limb thorax. CBS Publications and Distributors, PVT Ltd. Contents. Reference to the 6th edition. Reference of the 1st edition excerpts. Section 1, Upper Limb. Introduction. Parts of the upper limb. 3. Evolution. Upper limbs. 5. Study of anatomy. 5. 2. Bones of upper limb. Clavicle. Clavicle anatomy. Scapula. Clinical anatomy. Humerus. Clinical anatomy. Radius. Clinical anatomy. Ulna. Clinical anatomy. Importance of capsular attachments and epiphyseal lines. Clinical anatomy. Carpal bones. Clinical anatomy. Metacarpal bones. Clinical anatomy. Phalanges. Clinical anatomy. Siamoid bones of the upper limbs. Mnemonics. Facts to remember. Clinico-anatomical problems. Clinico-anatomical problems. Multiple choice questions. Pectoral region. Surface landmarks. Superficial fascia. Breast. Mammary gland. Lymphatic drainage. Clinical anatomy. Deep pectoral muscle into the pectoral region. Dissection. Acertus anterior. Mnemonics. Facts to remember. Clinio-anatomical problem. Multiple choice question. Axilla. Introduction. Dissection. Contents of axilla. Axillary artery. Relations on axillary artery. Axillary lymph nodes. Clinical anatomy. Branchial helix. Dissection. Clinical anatomy. Mnemonics. Facts to remember. Clino-anatomical problem. Multiple choice questions. Back. Surface landmarks. Skin and facial of the back. Scapular region. Cutaneous nerves, superficial veins and lymphatic drainage. Arms, muscles, forearm and hand. Joints of upper limb. Surface marking, radiological anatomy and comparison of upper and lower limbs. Appendix. Section 2, Thorax. Introduction. Bones and joints of thorax. Wall of thorax. Thoracic cavity and pleura. Lungs. Mediastinum. Pericardium and heart. Superior vena cava, aorta and pulmonary trunk. Trachea, esophagus and thoracic duct. Surface marking and radiological anatomy of thorax. Appendix. Spots. Index. Section 1, Upper limb. Introduction. Bones of the upper limb. Pectoral region. Axilla. Back. Scapular region. Cutaneous nerves, superficial veins and lymphatic drainage. Arm, forearm and hand. Joints of upper limb. Surface making, radiological anatomy and comparison of upper and lower limb. Appendix 1. Introduction. 1. On the forearm and hind limbs there They were evolved basically for bearing the weight of the body and for locomotion as in seen in quadrupeds, e.g., for example, cows and dogs. There are two parts of limbs are therefore built on the same basic principle. Each limb is made out of a basal segment or girdle and a free part divided into proximal, middle and distal segments. The girdle attaches the limb to the axial skeleton. The distal segment carries 5 digits. Table 1.1 shows homologous parts of upper and lower limbs. However, with the evolution of the erect posture in man, the function of weight bearing was taken over by lower limbs. Thus, the upper limbs, especially the hands, became free and regulatory, evolved into organ having great multiple skills. This has become possible because of wide range of mobility at the shoulder. The whole upper limb works as a joint lever. The human hand is a grasping tool. It is essentially adaptable to perform various complex functions under the control of a large area of the brain. The unique position of arm as a master mechanic of the animal world is because of the skilled movements of the human hands. Table 1.1 Homologous parts of the limbs: upper limb and lower limb, shoulder girdle, hip girdle, shoulder joint, hip joint, arm and humerus, thigh and femur, elbow joint, knee joint, forearm with radius and ulna, leg with tibia and fibula, wrist joint, ankle joint, foot with, hands with corpus dorsus, metacarpus and 5 digits. Parts of the upper limb. It has been seen that the upper limb is made out of 4 parts: shoulder region, arm and brachium, forearm and antebrachium, and hands of manus. Further subdivisions of these parts are given in the table 1.2 and figure 1.1. The shoulder region includes the pectoral or breast region on the front of the chest, the axial or armpit, and the scapular region on the back, comprising parts around the scapula. The bones of the shoulder girdle are the clavicle and the scapula. Of these, only the clavicle articulates with the axial skeleton at the sternoclavicular joint. The scapula is mobile and held in position by muscles. The clavicle and the scapula articulate with each other at the acromicrovial joint. The upper arm and brachium extends from the shoulder to the elbow. The bone of the arm is the humerus. Its upper end meets the scapula and forms the shoulder joint. The shoulder joint permits movement of the arm. The forearm antebrachium extends from the elbow to the wrist. The bones of the forearm are the radius and the ulna. At their upper ends, they meet at the lower end of the humerus to form the elbow joint. At the upper ends, they meet at the lower end of the humerus to form the elbow joint. The radius and the ulna each meet other at the radius ulnar joints. The elbow joints permits movement of the forearm, namely flexion and extension. The radiolar joints permit rotationary movements of the forearm, called pronation and supination. The mid-flexed elbow and the palms face upwards in superposition and downwards in pronation. During the last movement, The radius rotates around the ulna. Tables 1.2. Parts of the upper limb. Parts: shoulder region, upper arm, arm or branchion from shoulder to elbow, forearm from elbow to wrist and hand. Subdivision: pectoral region of the front of the chest, axillary or armpit, scapular region of the back. Joints: the hand. Manus includes the wrist or carpus, supported by 8 carpal bones arranged in 2 rows. The hand proper or metacarpus, supported by 5 metacarpal bones, 5-digit thumb or 4 fingers. Each finger is supported by 3 phalanges, but the thumb has only 2 phalanges, there being 14 phalanges in all. The carpal bones are from the wrist joint and with the radius, intercarpal joints with one another, and carpometacarpal joints the metacarpus. The phalanges from the metacarpophalangeal joints with the metacarpal and interophalangeal joints with one another. Movements of the hand permitted chiefly at the wrist joint. The thumb moves at the first carpometacarpal joint, whereas exclusive movements of the opposition besides the other usual movements are permitted. Each of the second to fifth digits move at the metacarpophalangeal, proximal and distal interphalangeal joints. Figure 1.2 and flowchart 1.1 shows the lines of force transmission. Force weight hand, wrist joint, radius, interosseous membrane, ulna, elbow joint, humerus, shoulder joint, scapula, coraloclavicular ligament, clavicle, sternoclavicular joint, sternum and axial skeleton. Bones of upper limbs. Introduction. Out of 206 total bones in the man, the upper limbs contain as many as 64 bones. Each side consists of 72 bones, the distribution of which is shown on Table 1.2 and Figure 1.1. The individual bones of the upper limbs will be described one by one. Their features and attachments should be read with the bones before undertaking the dissection of the part concerned. The paragraph on attachments should be revised when the dissection of a particular region has been completed. Clavicle. The clavicle, Latin, a small key, is a long bone. It supports the shoulder so the arm can swing clearly away from the trunk. The clavicle transmits the weight of the limb to the sternum. The bone has a cylindrical part called the shaft and 2 ends, lateral and medial. Site determination. The site to which a clavicle belongs can be determined from the following characters. The lateral end is flat and the medial end is large and quadrilateral. The shaft is slightly curved so that it is convex forwards in the medial 2/3 and concave forwards in its lateral 1/3. The anterior surface of grooved longitudinally in its middle 1/3. Peculiarities of the clavicle. It is the only bone that lies horizontally. It is subcutaneous throughout. It is the first bone to start ossifying. It is the only long bone which ossifies in membrane. It is the only long bone which has two primary centers of ossification. There is no medullary cavity. It is occasionally pierced by the middle supraclavicular nerve. It receives weight of upper limbs via lateral one-third coracoclavicular ligament and transmits weight to proper limbs to the axial skeletal via medial to third parts. Features: shaft. The shaft figure 2.1 and B is divisible into the lateral one-third and medial two-thirds. The lateral one-third of the shaft is flattened from above downwards. It has two borders, interior and posterior. The interior border is concave forwards. The posterior border is concave backwards. This part of the bone has two surfaces, superior and inferior. The superior surface is subcutaneous and the inferior surface presents an elevation called the conoid, Greek cone, tubercle and ridged called trapezoid ridge. The medial two-thirds of the shaft is rounded and is said to have four surfaces. The anterior surface is convex forwards. The posterior surface is smooth. The superior surface is rough in its medial part. The inferior surface has a rough oval impression at the medial end. The lateral half of the surface has a longitudinal subclavian groove. The nutrient ferment lies at the lateral end of the groove. Lateral and medial ends. The lateral or acromial, Greek, peak of shoulder, and is flattened from above downwards. It bears a facet that articulates with the acromotion process of the scapula to form the acromiclavicular joint. The medial or scranal end is quadrangular and articulates with the clavicular notch of the manubrium sterni to form the sternoclavicular joint. The articular surface extends to the interior aspect for articulation with the first costal cartilage. Shoulder, clavicle, arm, scapula, elbow, foramen, ulna, radius, wrist, hand, carpal bones, metacarpal bones, phalanges, parts and 32 bones of the upper limb. Evolution of upper limbs. The forelimbs have evolved from the pectoral fins of fishes. In tetrapods, terrestrial vertebrates, all the forelimbs are used for supporting the body weight and for locomotion. In arboreal, tree-dwelling human ancestors, the forelimbs have been set free from their weight-bearing function. The forelimbs, thus emancipated, acquired a wide range of mobility and were used for prehension or grasping, feeling, picking, holding, sorting, breaking, fishing, fighting, etc. These functions became possible only after necessary structural modifications such as the following were done. Appearance of the joints permitting rotationary movements of the forearms, described as supination and pronation, as a result of which food could be picked up and taken to the mouth. addition of the clavicle, which has evolved with the function of prehension, rotation of the thumb through 90 degrees so that it can be opposed to other digits for grasping. Appropriate changes for following mobility of the fingers and hands. The primitive para- pentadactyl links of amphibians terminating in 5 digits has persisted through evolution and is seen in a man. In some other species, however, the limbs are altogether lost, as in snakes, while in other digits are reduced in number, as in ungulates. The habit of branchiation, for it, on the other hand, suspending the body by the arms in anthropoid apes resulted in disproportionate lengthening of the forearms and also in elongation of the palms and the fingers. Study of anatomy. In studying the anatomy of any region by dissection, it is usually to begin by studying features of the skin, the superficial fascia and its contents, and the deep fascia. This is followed by the study of muscles of the region, and finally the blood vessel and nerves. These descriptions should be read only after the part has been dissected with the help of steps of dissection provided in the book. Before undertaking the study of any part of the body, it is essential for the students to acquire some knowledge of the bones of the region. It is for that reason that a chapter on bones osteology is given at the beginning of each section. While reading the chapter, the student should palpate the various parts of the bones on themselves. The next chapter must be studied with the help of loose human bones. Attachments at the lateral and the margin of the articular surface for its acromyoclavicular joint gives attachment to the joint capsule. At the medial and margin of the article surface of the sternum gives attachment to a fibrous capsule of stemoclavicular joint all around. Figure 2.2 and B. Articular disc posterosuperiorly. Interclavicular ligament superiorly. Lateral 1/3 of shaft. The interior border gives origin to the deltoid. Figure 2.21. The posterior border provides insertion to the trapezius. The conoid, tubercle and trapezoid ridge gives attachment to the conoid and trapezoid parts of the coracoclavicular ligament. Medial 2/3 of the shaft. Most of the anterior surface gives origin to pectoralis major. Half of the rough surface, superior surface gives origin to the clavicular head of the sternocleidomastoid. Figure 2.2a. The oval impression on the inferior surface at the medial end gives the attachment to the costoclavicular ligament. The subclavian groove gives insertion to the subclavius muscle. The margins of the groove gives attachment to the clavipectoral fascia. The posterior surface close to medial and gives origin to sternohyoid sternohyoid muscle, trapeze lateral and sternocleidomastoid medial and capsule of acromyoclavicular joint trapezius, trapezoid and conoid parts of coracoclavicular ligament, costoclavicular ligament, stamal and stemoid, medial and the subclavian vessels and cords of branchial plexus pass through the axial, lying between the inferior surface of the clavicle and upper surface of the first rib. Subclavius muscles act as cushion. The nutrient foramen transmit a branch of the suprascapular artery. Ossification. The clavicle is the first bone in the body to ossify. Except for the medial end, it ossifies in membrane. It ossifies from two primary centers and one secondary center. The two primary centers appear in the shaft between the fifth and the sixth week of intrauterine life and fuse about the 45th day. The secondary center of the medial and appears during 15 to 17 years and fuse with the shaft during 21 to 22 years. Occasionally, there may be a secondary center for the acromial end. Clinical anatomy.
Clinical anatomy. Clavicle is commonly fractured by falling on the obstructed hand or indirect violence. Outstretched hand. Clavicle is commonly fractured by falling on the outstretched hand, indirect violence. The most common site of the fracture is the junction between the two curvature. মাঝখানে এখানে প্রথম বেশি ফ্র্যাকচার হয়। Curvature of the bones, which is the weakest point. The lateral fragment is displaced downwards by the weight of the limb, as trapezius muscle along is unable to support the weight of upper limb. Clavicles may be congenitally absent or imperfectly developed in a disease called the cleidocranial dystosis condition. The shoulders drop and can be approximated anteriorly in front of the chest. Scapula. A scapula is a thin bone placed on the posterolateral aspect of the thoracic cage. The scapula has two surfaces, three borders, three angles, and three processes. এই দেখো, the lateral or glenoid Greek shallow form angle is large and bears the glenoid cavity. Dorsal surface is convex. তাহলে এগুলো পড়তে চাইলে তুমি ক্ল্যাভিকেলটা নিয়ে এসে large and bears the glenoid cavity. Dorsal surface is convex and is divided by the triangular spine into the supraspinous and infraspinous fossa. The costal surface is occupied by the concave subscapular fossa to feed on the convex chest wall. The thickest lateral border runs from the glenoid cavity above to the inferior angle below. Feature surface. The costal surface and subscapular fossa is concave and is directed medially and forwards. It is marked by three longitudinal ridges. Anterior thick ridge adjoins the lateral border. This part of the bone is almost rod-like. It acts as a lever for the action of serratus anterior and in overhead abduction in the arm. Of the arm, the dorsal surface gives attachment to the spine of the scapula, which divides three surfaces into smaller supraspinous fossa and a larger infraspinous fossa. The two surfaces are fossa are connected by the spinoglenoid notch situated border is thin and shorter. Near the root of the coracoid process, it presents the suprascapular notch. Lateral border is thick and the upper end is present the infraglenoid tubercle. Middle border is thin. It extends from the superior angle to the inferior angle. The superior angle is covered by the trapezius. Inferior angle is covered by the latissimus dorsi. It moves forwards round the chest when the arm is abducted. Lateral or glenoid angle is broad and pierces the glenoid cavity or fossa, which is directed forwards laterally and slightly upwards. Process border gallo, angle gallo, process. The spine or spinous process is a triangular bit of bone with three borders and two surfaces. It divides the dorsal surface of the scapula into the supraspinous and infraspinous fossa. Its posterior border is called the crest of the spine. The crest has upper and lower lips. The acromion has two borders, median and lateral, two surface, superior and inferior, and a facet for the capitally. The coracoid, Greek
Deltoid, acromion, pectoralis minor, coracoid process, coracobranchialis and short head of the biceps brachii, capsule of the shoulder joint, long head of the triceps brachii, lateral border of scapula, clavicle facet, capsule of acromicroclavicular joint, suprascapular ligament, omohyoid, inferior belly, first digitation, coracoclavicular ligament, third and second digitation, subscapularis, serratus interior, fourth and eighth digitation, attachment of the right scapular corset except trapezius, deltoid, supraspinatus, levator scapulae, rhomboid minor, circumflex subscapular artery, rhomboid major, acromion, coracobranchialis and short head of the biceps brachii, long head of biceps brachii, triceps brachii, long head, tres minor, infraspinatus, teres major, latissimus dorsi. Latissimus dorsi এখানে আছে দেখছো the long head of the triceps, the teres minor, arises from the upper two-thirds of the rough strip on the dorsal surface along the lateral border. The tres major arises from the lower one-third of the rough strip on the dorsal aspect of lateral border. The levator scapulae is inserted along the dorsal aspect of medial border from the superior angle to the root of the spine. The rhomboid minor is inserted into the medial border dorsal aspect opposite the root of the spine. The rhomboid major is inserted. The rhomboid major is inserted into the medial border dorsal aspect between the root of the spine and the interior angle. The inferior belly of the omohyoid arises from the upper border near the suprascapular notch. The margin of the glenoid cavity gives attachment to the scapule of the shoulder joint and to the glenoid labrum. The margin of the facet on the medial aspect on the acromion gives attachment to the scapule of the acromicrocular joint. The coracoacromial ligament is attached to the lateral border of the coracoid process and to the medial side of the tip of the acromion process. The coracohumeral ligament is attached to the root of the coracoid process. The coracoclavicular ligament is attached to the coracoid process, the trapezoid part of the superior aspect, and the coracoid part near to the root. The transverse ligament bridges across the suprascapular notch and converts it into a foramen which transmits the suprascapular nerve. The suprascapular vessel lie above the ligament. The spinal glenoid ligament may bridge the spinolagoid notch. The suprascapular vessel and nerve pass deep to it. Ossification. The scapula ossifies from one primary center and seven secondary centers. The scapula ossifies from one primary center and seven secondary centers. The primary center appears near the glenoid cavity during the 8th week of development. The first secondary center appears in the middle of the coracoid process during the first year and fuses by the 15th year. The subcoracoid center appears in the root of the coracoid process during the 10th year, fuses by the 16th to the 18th year. On the other centers, including two for the acromion, one of the lower two-thirds of the margin of the glenoid cavity, one of the medial borders, and one of the interior angle, appears at puberty and fuses by the 25th year. The fact of particular importance is centered with the acromion. If the two centers appearing for acromion fails to unite, it may be interpreted as a fracture on radiological examination. In such cases, a radiograph of the opposite acromion may mostly reveal similar failure of union. Paralysis of the stratus anterior causes winging of the scapula. The medial border of the bone becomes unduly prominent and arm cannot be abducted beyond 90 degrees. The scaphoid scapula is a developmental abnormality in which the medial border is concave. Humerus. The humerus is the bone of the arm. It is the longest bone of the upper limb. It has an upper and lower end and a shaft. Side determination. The upper end is rounded to form the head. The lower end is expanded from side to side, flattened from before backwards. The head is directly medial, upwards and backwards. The lesser tubercle projects from the front of the upper and is limited largely by the intratubercle sulcus or bicipital groove. Winging of right scapula. So winging. এখানে আছে great tubercle, anatomical neck, medial lip, lateral lip, deltoid tuberosity, anterior border, anterolateral surface, lateral supracondylar ridge, radical fossa, lateral epicondyle, capitulum, hole on capsule, lesser tubercle head, capsular line, intertubercle sulcus, medial border, nutrient foramen, anteromedial surface, chronoid fossa, medial supracondylar ridge, medial epicondyle, trochlea and medial ridge. Head covered with articular cartilage, capsular line, surgical neck, groove for radial nerve, medial border, epiphyseal line of medial epicondyle, anatomical neck, epiphyseal line, morphological neck, oblique ridge, deltoid tuberosity, lateral border. Features of right humerus seen from behind. Border. The upper one-third of the interior border forms the lateral lip of the intertubercle sulcus. In its medial part, it forms the interior margin of the deltoid tuberosity. The lower half of the interior border is smooth and rounded. The lateral border is prominent only at the lower end, where it forms the lateral supracondyle ridge. In the upper part, it is barely trackable up to the posterior surface of the greater tubercle. In the middle part, it is interrupted by the radial or spinal groove surfaces. The anterolateral surface lies between the anterior and lateral borders. The upper half of the surface is covered by deltoid. A little above the middle, it is marked by a V-shaped deltoid, Greek triangular shaped tuberosity. Behind the deltoid tuberosity, the radial groove runs downwards from the and forwards across the surface. The intermedial surface lies between the interior and medial borders. Its upper and one-third is narrow and forms the floor of the intertubercular sulcus. A nutrient foramen is seen on the surface in its middle near the medial border. The posterior surface lies between the medial and lateral borders. Its upper part is marked by the oblique ridge. The middle one-third is crossed by the radial groove. Lower end. The lower end of the humerus forms the condyle, which is expanded from side to side. It has articular and non-articular parts. The articular parts include the following.
Little head is rounded projection which articulated with the head of the radius capitulumটা যেখানে ছবি দেখো ক্যাপিচুলাম এই যে projection which articulates with the head of the radius trochlea হচ্ছে Greek pulley is a pulley shaped surface. They articulates with the trocar notch of the ulna. The middle edge of the trocar projects down 6 mm more than the lateral edge. This results in the formation of the carrying angle. The non-articular part includes the following. Middle epicondyle is prominent bony projection on the medial side of the lower end. It is subcutaneous and easy left to the medial side of the elbow. Lateral epicondyle is smaller than the medial epicondyle. Its anterolateral part has a muscular impression. The sharp lateral margin just above the lower end is called the lateral supracondyle ridge. The medial supracondyle ridge is a similar ridge on the medial side. The coronoid process fossa is a depression just above the anterior aspect of the trachea. It accommodates the coronoid process of the ulna when the elbow is flexed. The radial fossa is a depression present just above the anterior aspect of the capitulum. It accommodates the head of the radius when the elbow is flexed. The olecranon, Greek ulna head. Fossa lies just above the posterior aspect of the trachea. It accommodates the olecranon process of the ulna when the elbow is extended. Attachment. The multipinate subscapular is inserted. Multipinate subscapularis is inserted into the lateral tubercle. The supraspinatus is inserted into the uppermost impression on the greater tubercle. The infraspinatus is inserted into the middle impression on the greater tubercle. The teres minor is inserted into the lower impression on the greater tubercle. The pectoralis major is inserted into the lateral lip of the intertubercular sulcus. The insertion is bilaminar. এই দেখো এই আপার লিপে দেখো এটা হচ্ছে ব্র্যাঙ্কিওডাইলিস রেডিয়াল ফোসা, এটা হচ্ছে রেডিয়াল ফোসা। তারপর হচ্ছে এক্সটেন্সর কার্পি রেডিয়ালিস লঙ্গাস, কমন এক্সটেন্সর অরিজিন, এটা হচ্ছে কমন এক্সটেন্সর অরিজিন, এটা হচ্ছে ক্যাপিচুলাম এই, আর হচ্ছে ট্রকিয়া এই। ক্যাপিচুলাম হচ্ছে এটা, ট্রকিলিয়ার হচ্ছে এটা। ক্যাপিচুলাম গোল্লাটা, ট্রকিলিয়ার হচ্ছে এটা। ক্যাপসুলার লিগামেন্ট অফ দি এলবো, এখানে ক্যাপসুলার লিগামেন্ট অফ দি এলবো। তারপর হচ্ছে প্রোনেটর টেরিস, pronator teres, coronoid fossa, common flexor origin. ঠিক আছে, অ্যাটাচমেন্ট অবধি গেল। তারপর এটা হচ্ছে এই সাইডের
Head, capsular ligament of shoulder joint, radial groove, medial head of the triceps brachii, capsular ligament of
এটা
elbow,
এটা তুমি সামনের দিক দেখছো।
greater tubercle, supraspinatus, infraspinatus, teres minor, lateral head of the brachii,
টেরিস ব্রাঙ্কি
deltoid, branchialis, orecanon fossa,
ওরিকারন ফোসা, এটা হচ্ছে
onconius.
অনকনিয়াস মাসেল। দেখো এইটা হচ্ছে তোমার অ্যান্টেরিয়র ভিউ, সামনের ভিউ।
The latissimus dorsi is inserted into the floor of the intertubercle sulcus. The teres major is inserted into the medial hip of the intertubercle sulcus. The contents of the intertubercular sulcus are the tendon of the long head of the biceps brachii and its synovial sheath. The ascending branch of the anterior circumflex humeral artery. The deltoid is inserted into the deltoid tuberosity. The crocobranchialis is inserted into the rough area on the middle of the medial border. The branchialis arises from the lower half of the anteromedial and interolateral surface of the shaft. Part of the area extends onto the posterior aspect. The branchioradialis arises from the super two-thirds of the lateral supracondylar ridge. The extensor carpi radialis longus arises from the lower one-third of the lateral supracondylar ridge. The pronator teres humerus head arises from the lower one-third of the medial supracondylar ridge. The superficial flexor muscles of the forearm arises by a common origin from the interior aspect of the medial epicondyle. It is called the common flexor origin. The superficial intensor muscle of the forearm and supinator have a common origin from the lateral epicondyle. This is called the common extensor origin. The anconius, Greek elbow, anconius, arises from the posterior surface of the lateral epicondyle. Lateral head of the triceps brachii arises from the oblique ridge on the upper part of the posterior surface above the radial groove, while its medial head arises from posterior surface below the neck groove. The capsular ligament of the shoulder joint is attached to the anatomical neck except on the medial side, where the line of the attachment dips down by about 2 centimeters to include a small area of shaft within the joint cavity. The line is interrupted on the intratubercular sulcus to provide an aperture through which the tendon of the long head of the biceps brachii leaves the joint cavity. The capsular ligament of the elbow joint is attached to lower and long on a line along a line that reaches the upper limits of the radial and conoid fossae anteriorly and of the orecranon fossa posteriorly, so that these fossa lie within the joint cavity. Medially, the line of the attachment passes between the medial epicondyle and the trachea. On the lateral side, it passes between the lateral epicondyle and capitulum. 3 nerves are directly related to the humerus and are therefore liable to injury. The axillary at the surgical neck, the radial at the radial groove, and the ulna behind the medial epicondyle. Axillary deltoid muscle, deltoid tuberosity, radial nerve, ulna, olecranon fossa. Ossification. The humerus ossification from one The humerus ossifies from one primary center and seven secondary centers. The primary center appears in the middle of the diaphysis during the 8th week of development. The upper end ossifies from three secondary centers, one of the head first year, one of the greater tubercle second year, and one of the lesser tubercle fifth year. The three centers fuse together during the sixth year to form a epiphysis, which fuses with the shaft during the 20th year. The epiphyseal line encircles the bone at the level of the lowest margin of the head. This is the growing end of the bone. Remember that the nutrient foramen is always directed away from the growing end. The lower end ossifies from four centres, centres. The three centers fuses together during the sixth year to form one epiphysis, which fuses with the shaft during the 20th year. The epiphyseal line encircles the bone at the end of the lower margin of the head. This is the growing end of the bone. Remember that the nutrient forming is always directed away from the growing end. The center of the medial epicondyle appears during 4th to 6th year, forms a separate epiphysis and fuses with the shaft during the 20th year. Clinical anatomy. The common site of fracture of humerus are the surgical neck, the shaft, the supracondylar region. Supracondylar fracture is common in young age. Supracondylar fracture it is produced by a fall on the outer stretched hand. The lower fragment is mostly displaced backward so that the elbow is unduly prominent. As in dislocation of the elbow joint, this fracture may cause injury to the medial nerve. It may also lead to Volkmann's ischemic contracture caused by oculation of the bronchial artery. The three bony points of the normal elbow from the equilateral triangle is a flexed elbow and are in one line, an extended elbow. The humerus has a poor blood supply at the junction of its upper and middle thirds. The fractures at this site show delayed union or non-union. The head of the humerus commonly dislocates inferiorly.
Humerus ossifies from one primary center and seven secondary centers. The primary center appears in middle of the diaphysis during the 8th week of development. The upper end ossifies from three secondary centers, one for the head first year, one for the greater trochanter second year, and one for the lesser trochanter fifth year. The three centers fuse together during the sixth year to form one epiphysis, which fuses with the shaft during the 20th year. The epiphyseal line encircles the bone at the level of lowest margin of the head. This is the growing end of the bone. Remember that the nutrient foramen is always directed away from the growing end. The lower end ossifies from four centers which form two epiphyses. These centers include one for the capitulum and the lateral flanks of the trochanter trochlear first year, one for the medial flanks and the trochlear ninth year, one for the lateral epicondyle 12th year. All these fuse during the 14th year to form one 14th year to form one epiphysis, which fuses with the shaft at about 16 years. The center for the medial epicondyle appears during the 4 to 6 years, forms a separate epiphysis and fuses with the shaft during 20th year. Clinical anatomy. The common site of fracture of humerus are the surgical neck, the shaft, and the second supracondylar region. Supracondylar fracture is common in young age. It is produced by a fall on the outstretched hand. The lower fragment is mostly displaced backwards so that the elbow is unduly prominent, as and the dislocation of the elbow joint. This fracture may cause in injury to this fracture may cause injury to the median nerve. It may also lead to the Volkmann's ischemic contracture caused by the occlusion of the brachial artery. The three bony points of the normal elbow from the equilateral triangle in a fixed elbow and are in one line is an extended elbow. The humerus has a poor blood supply at the junction of the upper and medial thirds. Fracture of the side show the delayed union or non-union. Head of the humerus commonly dislocated inferiorly. Radius. Radius is the lateral bone of the foramen and is homologous with the tibia of the lower limb. It has an upper end, a lower end, and a shaft. Side determination. Upper end is having disc-shaped head, while lower end is expanded with a styloid process. At the lower end, the anterior surface is in the form of thick prominent ridge, while the posterior surface presents four grooves for the extensor tendons. The sharpest border of the shaft is the medial border. Close to neck, it presents a radial tuberosity. Lower end present a tubercle on the posterior surface and called as dorsal tubercle to blister. Features. Upper end. Head is disc-shaped and covered with hyaline cartilage. It has a superior concave surface which articulates with the capitulum of the humerus at the elbow joint. The circumference of head is also articular. It fits into a socket formed by the radial notch of ulna and the annular ligament, thus forming the superior radioulnar joint. The neck is enclosed by the narrow lower margin of the annular ligament. The head and neck are free from capsular attachment and can rotate freely with the socket. Tuberosity lies just below the medial part of the neck. It has a rough posterior part and a smooth anterior part. দেখো হিউমারাসের ossification of the humerus, radius and ulna.
Humerus, shaft, upper end head, greater tubercle, lesser tubercle, lower end capitulum plus lateral, part of trachea, medial part of trachea, lateral epicondyle, medial epicondyle, radius, shaft, lower end and upper end. 8 weeks of development, 8 weeks of development, ulna, 8 weeks of development. তার মানে অংশগুলো হচ্ছে shaft, upper end and head, greater tubercle, lesser tubercle, lower end capitulum, part of trachea, medial part of trachea, lateral epicondyle, medial epicondyle, shaft, lower end, upper end, ulna, shaft, lower end, upper end. Clawing of fingers and thumb, wasting of forearm, occlusion of brachial artery, supracondyle fracture of humerus. Shaft. It has 3 bones and 3 surfaces. 20th year, 16th year, 14th year, 18th year, 16th year. Borders. The anterior border extends from the anterior margin of the radius tuberosity to the styloid process. It is oblique in the upper half of the shaft and vertical in the lower half. The oblique part is called the anterior oblique line. The lower vertical part is just like the posterior border is the mirror image of the anterior border but is clearly defined only in its middle one-third. The upper oblique part is known as the posterior oblique lines. The medial or interosseous border is the sharpest of the three borders. It extends from the radius tuberosity above the posterior margin of the ulnar notch below. The interosseous membrane is attached to its lower three-fourths. It is lower part. It forms the posterior margin of the elongated triangular area surfaces. The anterior surface lies between the anterior and intraosseous borders. A nutrient foramen opens in the upper part and it's directed upwards. The interior artery is a branch of artery interosseous artery. Branch of artery. Branch of interior interosseous artery. Figure 2.23. Lateral epicondyle, medial epicondyle, olecranon process. Medial epicondyle, lateral epicondyle, olecranon process. Relationship of lateral epicondyle, olecranon process and medial epicondyle. Flexed elbow and extended elbow. Acromion, normal position of humerus. Humerus dislocated inferiorly. The posterior surface lies between the posterior and the interior borders. The lateral surface lies between the interior and the posterior borders. It shows a roughened area in its middle part. Lower end. The lower end is the widest part of the bone. It has 5 surfaces. The interior surface is the form of a thick, prominent ridge. The radial artery is palpated against the surface. Neck head. Radius tuberosity with rough posterior part and smooth anterior part. Anterior border. Nutrient foramen. Medial border. Radial artery. Styloid process. Epiphyseal line. Capsular line. Features of right radius. Anterior aspect. Rough area for pronator tears. Posterior border, apical line, capsular line, oblique groove, dorsal tubercle, styloid process. Features of right radius, posterior aspect. Anterior border, lateral surface, posterior border. Anterior surface, medial border, lateral border. Posterior border, medial surface, anterior border. The radius and the ulna of transverse section. Interior surface of radius and ulna. Radius for scaphoid, ulna notch, ulna. Lateral border, posterior border, posterior border. The posterior surface presents four grooves of the extensor tendons. The dorsal tubercle of Lister lies lateral to an oblique groove. The medial surface is occupied by the ulnar notch for the head of the ulna. The lateral surface of prolonged downwards to form a styloid, Greek pillar, styloid, Greek pillar process. The inferior surface bears a triangular area for the scaphoid bone, a medial quadrangular area for the longnate bone. Its surface takes part in forming the wrist joint attachments. The biceps Latin, two heads, biceps, two heads. Branchi is inserted into the rough posterior part of the radial tuberosity. The anterior part of the tuberosity is covered by a brusa, figure 2.25 and 8.4. The supinator, Latin for bent back, is inserted into the upper part of the lateral surface. The pronator teres is inserted into the middle part of the lateral surface. The branchioradialis is inserted into the lower part of the lateral surface just above the styloid process, figure 2.25. The radial head of the flexor digitorum superficialis takes origin from the anterior oblique line and the upper part of the anterior border. The flexor pollicis, Latin thumb, longus, takes origin from the upper two-thirds of the anterior surface, 2.25. The pronator quadratus is inserted into the lower part of the anterior surface and into the triangular triangular area on the medial side of the lower end. The radial artery is palpated for radial pulse, as it lies medial to the sharp anterior border of radius, lateral to the tendon of flexor carpi radialis. The abductor pollicis rough and the extensor pollicis brevis rises from the posterior surface. The quadrate ligament is attached to the medial part of the neck. The oblique cord is attached on the medial side just below the radial tuberosity. The articular capsule of the wrist joint is attached to the anterior and posterior margins of the inferior articular surface. The articular disc of the inferior radiolar joint is attached to the lower border of the ulnar notch. The extensor retinaculum is attached to the lower part of the anterior border. The interosseous membrane is attached to the lower three-thirds of the interosseous border. Olecranon process, capsular ligament, branchialis head, oblique cord, supinator, flexor digitorum, superficialis, radius, pronator teres, flexor pollicis, longus, radius artery, brachiocardialis, styloid process, capsular ligament, flexor digitorum, superficialis, pronator teres, biceps brachii, flexor digitorum, profundus, anterior border, pronator quadratus, capsulus ligament, steroid process, attachment of the articular disc, attachment of the right radius and ulna, anterior aspect, triceps brachii, aconneus, common aponeurosis for the flexor carpi ulnaris, extensor carpi ulna and flexor digitorum profundus, flexor digitorum profundus, extensor pollicis longus, ulna, extensor indicis, posterior border, medial surface, head of ulna, styloid process, dorsal tubercle, posterior border, interosseous border, extensor pollicis brevis, pronator teres, abductor pollicis longus, radius, supinator, head of radius, olecranon process. Figure 2.26. Attachment of the right radius and ulna, posterior aspect. The first groove between chest, like lower part of the anterior border and styloid process, gives passage to abductor pollicis longus and extensor pollicis brevis. The second groove between the styloid process and the dorsal tubercle gives way to extensor carpi radius longus and extensor carpi radialis brevis tendons. The third oblique groove medial to dorsal tubercle gives passage to extensor pollicis longus tendon. The fourth groove of the medial aspect gives passage to the tendon of extensor digitorum, extensor indicis, posterior interosseous nerve and interior interosseous artery. In addition to the junction of the lower end of radius and ulna, passes the tendon of extensor digiti minimi. Lastly, in relation to ulna, between its head and its styloid process, traverse the tendon of extensor carpi ulnaris. There are 6 compartments under extensor retinaculum of wrist. 4 are the relation to radius, 5th at the junction of the radius ulna, and 6th on the ulna itself between its head and its styloid process. Ossification. The shaft ossifies from a primary center which appears during the eighth week of the development. Eighth week of development. The lower end ossifies from a secondary center which appears during the first year and fuses at 20 years. It is the growing end of the bone. The upper head ossifies from a secondary center which appears during the fourth year and fuses at 18 years. Clinical anatomy. The radius commonly gets fractured about 2 centimeters above the lower end, Colles fracture. This fracture is caused by a fall on the outstretched hand. The distal fragment is displaced upwards and backwards, and the radius steroid process comes to lie proximal to the ulnar styloid process. It normally lies distal to the ulnar steroid process. If the distal fragment gets displaced anteriorly, it is called Smith's fracture. A sudden powerful jerk on the hand of a child may dislodge the head of the radius from the grid of the annular ligament. This is known as subluxation of the head of the radius, pulling elbow, figure 2.29. The head can normally be felt in a hollow behind the lateral epicondyle of the humerus. Figure 2.26. Tendons in the 1 to 6 compartments of the posterior surface of lower ends of radius and ulna. Extensor pollicis longus tendon, dorsal tubercle. Extensor carpi radius brevis tendon. Extensor carpi radialis longus tendon. Extensor pollicis brevis tendon. Abductor pollicis longus tendon. Sharp anterior border. Extensor digitorum tendons. Extensor indicis tendon, extensor digiti minimi tendon, extensor retinaculum, extensor carpi ulnaris tendon. Colles fracture on the dinner fork, deformity, Smith fracture, ulnar radius, head of the ulna, pulled elbow
of the forearm and is homologous with the fibula of the lower limb. It has upper end, shaft and lower end. Side determination. Upper end is hook-like with its concavity directed forwards. The lateral border of the shaft is sharp and crest-like. Pointed styloid process lies posteromedial to the rounded head of ulnar at its lower end. Feature. Upper end. Upper end present the olecranon and coronoid process and the trochlear and the radial notches. The olecranon process projects upwards from the shaft. It has superior, anterior, posterior, medial and lateral success. The anterior surface is articular. It forms the upper part of the trochlear notches. The posterior surface forms a triangular subcutaneous area which is separated from the skin by the bursa. Inferiorly, it is continuous with the posterior border of the shaft of the ulna. The upper part forms the point of the elbow. Tubercular notch, olecranon process, coronoid process, ulna, apex of the articular disc and the inferior radio joint, head of the ulna, ulnar collateral ligament of the styloid process. Feature of anterior aspect of ulna and upper end of the ulna. The medial surface is continuous inferiorly with the medial surface of the shaft. The lateral surface is smooth, continuous as posterior surface of shaft. The superior surface is in its posterior part shows a roughened area. The coronoid, Greek it like cross back process projects forwards from the shaft just below the olecranon and has four surfaces, namely superior, anterior, median and lateral. Superior surface forms the lower part of the trochlear notch. The anterior surface is triangular and rough, and its lower corner forms the ulnar tuberosity. Upper part of the lateral surface is marked by the radial notch of the head of the radius. The annular ligament is attached to the anterior and posterior margins of the notch. The lower part of the lateral surface forms a depressed area of the accommodate and the radial tuberosity. It is limited behind by a ridge is called the supinator crest. Medial surface is continuous with the medial surface. Medial surface is continuous with the medial surface of the shaft. The trochlear notch forms an articular surface that articulates with the trochlea of the humerus to form the elbow joint. The radial notch articulates with the head of the radius to form the superior radio ulnar joint. Superior radio ulnar joint. Shaft. The shaft has three border and three surface. Shaft has three border and three surface. Borders. আমরা ইয়েগুলো নিয়ে বোনসগুলো নিয়ে পড়লে ভালো হতো না? Borders. The interosseous and lateral surface is sharpest in the medial 2/4. Inferiorly, it can be trochanted to the lateral side of the head. Superiorly, it is continuous with the supinator crest. The anterior border is thick and rounded. It begins above on the medial side of the ulnar tuberosity, passes backwards in its lower 1/3 and terminates at the medial side of the styloid process. The posterior border is subcutaneous. It begins above at the apex of the triangular subcutaneous area at the back of the olecranon. The terminates at the base of the styloid process. Surface. Anterior surface lies between the anterior and interosseous borders. A nutrient foramen is seen on the upper part of this surface. It is directed upwards. The nutrient artery is derived from the anterior interosseous artery. Medial surface lies between the anterior and posterior border. Posterior surface lies between the posterior and interosseous border. It is subdivided into three areas by two lines. An oblique line divides it into upper and lower parts. The lower part is further divided by a vertical line into a medial and lateral area. Lower end. The lower end is made up of the head and styloid process. The head articulates with the ulnar notch of the radius to form the inferior radioulnar joint. It is separated from the wrist joint by the articular discs. Ulnar artery and the nerve lie in the anterior aspect of the head of ulna. The styloid process downwards from the posteromedial side of the lower end of the ulna. Posteriorly, between the head of the styloid process, there is groove for the tendon of the extensor carpi ulnaris. Attachment. The triceps brachii is inserted into the rough posterior part of the superior surface of the olecranon. Anterior part of the surface is covered by a bursa. And the medial surface of the olecranon. Superior surface, olecranon process, posterior surface, radial notch, superior crest, and the oblique lines of the posterior surface. Medial surface and the vertical line on posterior surface. Posterior border gives origin to flexor digitorum profundus, flexor carpi ulnaris, extensor carpi ulnaris, and the lumbroprocessus membrane on the lateral border. The brachial is inserted in the anterior surface of the coronoid process, including the tuberosity of the ulna. The supinator arises from the supinator crest and from the triangular area in front of the crest. Ulnar head of the flexor digitorum superficial arises from the tubercle at the upper end of the medial margin of the coronoid process. The ulnar head of the pronator teres arises from the medial margin of the coronoid process. Flexor digitorum profundus Latin deep arises from upper 3/4 of the anterior and medial surface of the shaft, medial surface of the coronoid and olecranon process. The posterior border of the shaft through an aponeursis, which also gave origin to the flexor carpi ulnaris and the extensor carpi ulnaris. The pronator quadratus takes origin from the oblique ridge on the lower part of the anterior surface. The flexor carpi ulnaris arises from the medial side of the olecranon process and from the posterior border. The extensor carpi ulnaris arises from the posterior border. The and Anconus is inserted in the lateral aspect of the olecranon process and the upper one-fourth of the posterior surface of the shaft. Lateral part of the posterior surface give origin from above downwards to the abductor pollicis longus. The extensor pollicis longus and the extensor indicis. The interosseous membrane is attached to the interosseous border. The oblique cord is attached to the ulnar tuberosity. The capsular ligament of the elbow joint is attached to the margin of the trochlear notch to the coronoid and the olecranon process. The annular ligament of the superior radioulnar joint is attached to the two margins of the radial notch of the ulna. The ulnar collateral ligament of the wrist is attached to the styloid process. The articular disc of the inferior radioulnar joint is attached by its apex to a small rough area just lateral to the styloid process. Ossification. The shaft and the most of the upper end ossify of a primary center which appears during the 8th week of development. Superior part of the olecranon process ossifies from a secondary center which appears during the 10th year. It forms a scale-like epiphysis which joins in the rest of the bone by 16th year. Lower end ossifies from the secondary centers, which appears during the 5th year, joins with the shaft by 18th year. This is growing end of the bone. Clinical anatomy. Ulna is establishing bone of the forearm with its trochlear notch, grabbing the lower end of the humerus. On this foundation, the radius can pronate and supinate for efficient working of the upper limb. Shaft of the ulnar may fracture either alone or along with that of the radius. Cross union between the radius and ulna must be prevented to preserve the pronation and supination of the head. Dislocation of the elbow is produced by a fall on the obstetric's hand with the elbow strictly flexed. The olecranon shifts posteriorly and the left is fixed in the slight flexion. Normally, it is an extended elbow. The tip of the olecranon lies in the horizontal line with the two epicondyla of the humerus and is flexed elbow. The three bony points form an equilateral triangle. These relations are distributed dislocation of the elbow. Fracture of the olecranon is common and is caused by a fall on the point of the elbow. Fracture of the coronoid process is uncommon and usually accompanies dislocation of the elbow. Medilungs deformity is dorsal subluxation, displacement of the lower end of the ulna due to retarded growth of the lower end of the radius. Ossification, humerus, radius and ulna. Law of ossification. The long bones processing epiphysis at both their ends. The epiphysis of the end, which appears first, is last to join with the shaft, as chorally epiphysis which appears last is first to join. These ends of long bones which unite last with this shaft are designed as growing end of the bone. In case of long bones of the upper limb, growing ends are at shoulder and wrist joint. This implies that the upper end of humerus and lower end of the both radius and ulna are growing ends, and each will therefore unite with their shaft at a later period than their corresponding other ends. Direction of the nutrient foramen in these bones as a rule is opposite to the coring end. Time of appearance and fusion either of various parts at one end and with the shaft are given in table 2.1. Importance of the capsular attachment and epiphyseal lines. Metaphysis is the epiphyseal end of diaphysis. It is actively growing part of the bone which receives blood supply. Infection is the part of bone are most common in the young age. The epiphyseal line is line of union of metaphysis with the epiphysis. At the end of the bone, besides the epiphyseal line, is the attachment of the capsule of the respective joints. So, infection in the joint may affect the metaphysis of the bone if it is partly or completely inside the joint capsule, as coral part of bone which reach blood supply. Understand? Infection is the part of bone are most common in the young age, কারণ এখানে ব্লাড সাপ্লাই বেশি, ইনফেকশন এখানে বেশি হয়। The epiphyseal line is the line of union of epiphysis with the metaphysis with the epiphysis. At the end of the bone, beside the epiphysis line, is the attachment of the capsule of the respective joints. So, infection in the joint may affect the metaphysis of the bone if it is partly or completely inside the joint, inside the joint capsule. As corally, the disease of metaphysis, if inside a joint, may affect the joint. So, it is worthwhile to know the intimate relation of the capsular attachment and the epiphyseal line at the end of the humeral radial ulnar bones as shown table 2.2. Clinical anatomy. Relation of the capsular attachment and the epiphyseal line. If epiphyseal line site of union of the epiphysis and metaphysis end of diaphysis is intracapsular, intra, extra, inter, এগুলো বুঝতে হবে। Intracapsular of the infection of the joint are likely to affect the metaphysis, the actively growing part of the bone, especially in young age. Intra মানে কি? Carpal bones. Carpus is Greek carpus wrist, made up of 8 carpal bones which are arranged in 2 rows. Proximal rows contains from lateral to medial side the scaphoid, Greek bow twist, lunate, Latin moon shaped, the triangular, Latin 3 carried, the pisiform, Greek P. Distal low contains in the same order trapezium, Greek 4-side geometric figure, trapezoid, Greek baby's shoe, the capitate Latin hat, the hamate Latin hook. Identification. The scaphoid is boat shaped and has a tubercle on its lateral side. Lunate is half moon shaped or crescentic. The triculentar is pyramidal in shape and has an isolated oval facet on the distal part of the palmar surface. The pisiform is pie-shaped and has only one oval facet on the proximal part of the dorsal surface. The trapezium is quadrangular shape, has a crest and a groove anteriorly. It has a cellar, concavo-convex, and articular surface distally. The trapezoid resembles the shoes of a baby. The capitate is the largest carpal bone with the rounded head. The hamate is red-shaped with a hook near its base.
Relation of capsular attachment and epiphyseal lines. Humeral upper end, lateral to the anatomical neck, medial 2 cm below shaft. At the lowest part of the articular surface to the head. Metaphysis is particularly intracapsular. Humerus and lower end follows the margin of radius and coronoid fossae and the olecranon fossa. Both epicondyle are extracapsular. A horizontal line at the end of epilateral condyle. Medial epicondyle owns a separate epiphyseal line. Metaphysis is partly intracapsular. Radius and upper end. Attaches to the neck of the radius, the head of forms the epiphysis. Metaphysis is transcapular. Radius lower end, close to articular margin all around. Horizontal line at the end of the upper part of lunar notch. Metaphysis is completely transcapular. Ulna upper end, near the articular surface of ulna. Scale-like epiphysis on the upper surface of olecranon. Metaphysis and part of diaphysis is related to capsular line. The epiphysis is transcapular. ulna lower end, around the head of ulna, horizontal line at the end of articular surface of radius. Metaphysis is partly intracapsular. Site determination. General points. The proximal row is convex proximally and concave distally. The distal row is convex proximally and flat distally. Each bone has 6 surfaces. The palmar and dorsal surface are non-articular except the except for the trunquentral and pisiform. The lateral surface of the two lateral bones, sphenoid and trapezium, are non-articular. The medial surface of the three medial bones, trunquentral, pisiform, and hamate, are non-triquentral. The dorsal non-articular surface is always larger than the palmar non-articular surface, except for the lunate, in which the palmar surface is larger than the dorsal. The general points help in identifying the proximal, distal, palmar, and dorsal surfaces is most of the bones. The site can be finely determined with the help of the specific points. The sphesoid, the tubercle, is directly lateral forward and downwards. The lunate, a small seminular articular surface of the sphenoid, is on the lateral side. A quadrilateral articular surface for the articuatral is on the medial side. The triquentral, the oval facet for the pisiform, lies on the distal part of the palmar surface. The medial and the dorsal surface are continuous and non-articular. The pisiform, the oval facet for the triquentral, lines on the proximal part of the dorsal surface. The lateral surface is grouped by the ulnar nerve. The trapezium, the palmar surface, has a verticular groove for the tendon of the flexor carpi radialis. The groove is limited laterally by the crest of the trapezium. The dorsal surface bears a cellular convex articular surface for the base of the first metacarpal bone, the trapezoid. The distal articular surface is bigger than the proximal. The palmar non-articular surface is prolonged laterally. The capitate, the dorsomedial angle, is the distalmost projection from the body of the capitate. It bears a small facet for the fourth metacarpal bone, the hamate. The hook projects from the distal part of the palmar surface and is directed laterally.